For today, I'm going to focus primarily on this end of the spectrum and my work there as I catch people at the county safety net. I'm also going to defer on answering any individual questions about particular cases. And if you'd like to talk about that, we can talk about that afterwards. But I will answer all questions about the system at EPS. Oh, right, this one doesn't work. So, the 5150. For those of you who may or may not have heard about it, the 5150 is essentially the involuntary civil commitment process when, because of a mental illness, you are so concerned about someone's general safety and even their ability to take care of themselves, you can then initiate a 5150. And the 5150 is underneath what's called the LPS for short, like law, Lanterman-Petrus short. I am by no means a California native, and this goes way back, back before I was even paying attention to this stuff. And I'm not going to try to speak about it intelligently because this goes back to even Ronald Reagan's time. It's the earliest time that I can remember. And so someone else can speak a little bit more about the true definition of gravely disabled or some of the more specific nuances of the language behind LPS law. But suffice to say, I'm going to focus on the 5150 today because that's typically what comes through Valley Medical Center's EPS. People are usually brought in on a 5150 and they're with me for up to 72 hours. Well, me, an EPS for up to 72 hours. I'm only there for 16 hours. Oh man, I forgot that's a long period of time. Been doing it for so long that I've gotten used to it. So 5150s in real life. I didn't know, so I'm originally from Philadelphia, and I came here from the East Coast, obviously, and what I found is that here in each county in California, each person who writes a 5150 needs to go through a certification process. And just as I work in San Mateo County, also I had to get 5150 certified up there as well. And there's also a refresher in your license that you have to keep getting. And so not just anybody can write a 5150. These are the people who typically can. The Santa Clara County police departments, the sheriff's office, physicians, again, all these people have to go through the certification process, but they can write 5150s. And outside hospitals usually have emergency room doctors who are also 5150 certified and will also send people, transfer people to EPS from their hospital. The other place where we frequently get 5150s is from our neighboring mental health urgent care clinic, which is right next to EPS on the other side of the locked doors. And then we'll also get people coming from Maine Jail and community board and care homes. If anybody has any particular questions about the terminology I've used so far, feel free to stop me. But this is where 5150s typically come from. One bullet I didn't want to miss here. I really appreciate the importance of crisis intervention training for our police officers. A lot of times they don't get as much training in the academy in dealing with mental health crises, and I just want to thank NAMI's support in working with the police officers who are out there and helping to provide more sensitive approach to people who are going through a mental health crisis, because it can be very intimidating already when you're having a tough time, but then to have the police show up, that just sometimes escalates things. So having a sensitive police officer who's well trained is really, really important in starting to de-escalate the crisis. So EPS, it's obviously a locked psychiatric floor. It's not technically a hospital, it's the psychiatric emergency room. However, we have multiple locked doors in place in order to maintain safety and to prevent people from leaving before they're ready. So as you can see, I've put up bullet points for the different locked doors that are available. And when the police usually show up and park their car in front of EPS, they go through the first door when they ring the doorbell. And so even from a very early point, there's already safety and security in mind. There are no firearms allowed on the premises of EPS. This includes the police. So there's actually gun lockers that are there. Or the police usually put the guns that they do have back in their car in the secured area there. And then there's a series of more doors that they go through as the paperwork progresses. And at some point, the police or the ambulance drivers have essentially handed off the patient to my nurses, and then we will start the triage process itself. So the third locked door is usually where the police are removing the handcuffs, and that's the beginning of the EPS process. At EPS, I should mention that my colleagues who are on with me consist of all of these different categories of people. They're mental health workers. Bev had mentioned that I was a psychiatric technician in a previous life, and that was me before I had all of my training, and they're usually there to help supervise and support and maintain the structured milieu. Then there's also the psychiatric nurses. The fewest I've ever seen there was 5. And the reason why I say that is because the number of nurses can fluctuate based off of how many patients are there, which can be anywhere from 0, which I've once gotten it to I think I've seen it at like 40 or 50 sometimes too. So it varies. Let's see, and then of the psychiatrists, there's usually at least one, and that's typically only on the overnight from 10 p.m. to 8 a.m., where there's only one psychiatrist overnight. But usually there's anywhere from 2 to 3 during the 8 a.m. to 10 p.m. period during the daytime. So once the police leave, then begins the triage process. And I say this because different people are sort of collecting around the person when they first show up in EPS and come through the locked doors. But we have a public safety officer at EPS. One is always there. And he or she normally does the metal detector screening to make sure, again, that safety is monitored and that there's not anybody who has any metal weaponry hidden anywhere. There's a very thorough belongings check done by the mental health workers, supervised also at the same time by the public safety officer, and there's a very thorough cataloging of every single person's belongings. And there's a sheet of paper there as a record because when they leave or are transferred out of the hospital, there's documentation and cataloging of all the belongings. Things that are prohibited at EPS. Not only is safety really important at EPS, but patient privacy is also really important to us as well. For that reason, there are no personal cell phones allowed, 0. That is confiscated at the beginning and placed into the locked safe area of EPS. Also, because of safety concerns, there are no belts or strings, shoelaces, anything that could potentially be used to harm yourself with. And then per California state law, you can't smoke anywhere near a healthcare organization place. So there is no tobacco, no smoke breaks anymore, which is a little bit different from where I came from in Virginia, where I guess tobacco is grown, and maybe they just haven't had the chance to change around their laws just yet. Let's see. So after the security officers and the mental health workers have had a chance to do the initial screening process, The nurses will then start to do their brief discussion with the patient and start gathering some brief medical tidbits, any seizure history. They'll do a set of vital signs, check their blood pressure, make sure they're not in any pain. They'll also do an alcohol breath test. Sorry, I called it the breathalyzer. That's kind of a sign of the age that I come from. And then we also prompt patients to provide a urine specimen because as typically part of our safety screening, we like to make sure that any substances that people might potentially be under is something that we're aware of, and that if we do decide to give medications, we're fully aware of what we're doing. Well, at least we try to be as fully aware as we can. And then comes, oh, I have a question in the back.
On the nurse screening, do they have good access to the patient's records? Because we know people cycle in and out of UPS with alarming frequency. So is there good access to the records?
Excellent question. So it was asking, is there easy access to past records? And let me say that Santa Clara County has done an extensive amount of investment into the electronic medical record system. It's called EPIC. Most doctors kind of cringe a little bit when they hear about electronic medical records, but honestly at EPS, it has made the biggest difference in a lot of my care. I can see records going back to, I think the farthest back I've gone is like 2010. And if if that patient has signed the proper documentation, I can actually even see their records over at Kaiser. I can see it over at El Camino. I can see it from Maine Jail. It is across the board one of the big, most revolutionary changes in the electronic medical record system that I've seen. And it provides a lot of really great information. What I'll say is that the EPIC electronic medical record system is very comprehensive, but also requires some investment. And so not everybody has access to EPIC electronic medical record system.
Do the RNs have special training certification?
Oh, absolutely. So nurses, obviously they go through nursing school. They have a licensing exam. Typically, a lot of the nurses that we have gone through, I guess, what's the word? I'm trying to think of the word. But they're basically like a trial period whereby they're mentored and supervised by one of the senior psych nurses there. And there's a very thorough vetting process before they're put into EPS and allowed to run in a more independent fashion. Does that answer your question?
Yes.
Oh, okay. All right. Ooh, more questions. Okay. Yeah? Boy. You, okay. Okay. Well, so I'm sorry, I'm not actually aware of the AB 1424. So, yeah. Okay.
And in that too, there's things, the laws do state, or like the privacy and all that, that there are things that are the best interest of the patient. And anyway, but that's the problem, I guess, is that all those who know about it. It's like some of the I could not get it, it was, a real struggle. And other hospitals, it just, we set up different, I don't know why it is, yes, but it just, this division is really bad in families, that family is relevant.
Well, I will touch upon that, and certainly I had a feeling that this topic itself would come up, and we should talk about it, because I will say that at EPS, I have always appreciated family members who are willing to come in, who are willing to visit, who are willing to help provide information that would be helpful in figuring out what to do next. That being said, we'll touch upon the family part a little bit later, but I would like to hear a little bit more about this document you talk about, because I would be shocked if you were willing to leave documentation and information for the EPS staff, and that it was just not taken in and added into the paper, into the chart, because if it is something that could lead to clinical decision-making changes, I would want to see it. So, well, yeah.
Obligation for everybody to do it. This is something priority. We need to educate what's not better hospitals, as there is more this legislation. And I think information good is okay. But you have sense. I think that it's not something that's fully that we want, and so it's a big priority for me. So, the
Okay.
fact, we just need to educate the doctor, and then I was saying that that's a priority for me.
Oh,
Order, you want
I will definitely take a look at it afterwards, because you all know about it, and I've been on the front lines and trying to figure out what to do for some of these cases, and trying to piece everything together with all the information available is obviously the best thing. So it's interesting that I haven't had the chance to run across this form just yet since my time at EPS, but yeah, we're going to cover that part too. That is also a frequently difficult gap to navigate. Oh yeah.
some of the other hospitals that they want, and I'm talking to all of them, they're not telling me, they want information. Such a blessing that I feel. There's, somebody knows better than me. So I've been talking to
we could certainly talk about that more. There's a lot of hands that have gone up, and I'm kind of wondering if I should save it for the end or if we should cover it now. Oh, right, right. This is true too. Uh-oh, something happened here. Okay, but we will get to each and every question, because I'd certainly like to hear more. I've never had the chance to actually go to the NAMI Santa Clara headquarters, and I've always wanted to get a better connection with the community itself. So finally coming down to me and when we sort of get the chance to say hello and do like a brief sort of introduction, each patient gets a brief screening from the psychiatrist, and we check to make sure there's not any medical urgencies that need to be sent back to the main emergency room for assessment and evaluation and treatment. We'll put in orders for labs. We'll make sure that they get diet orders, and if there's any other like medical condition that requires medications, we will start those medications. In this case, I've highlighted alcohol withdrawal. There's also hypertension, and for some who come in really, really agitated and dangerous, we will have to offer medications at that point in order to help them maintain their safety while they're at EPS. Because at that point, it can be, again, very disorienting and very aggravating in some ways to be in EPS. At that point, the patient's primary nurse then takes on the case and actually collects a very thorough medical history, psychiatric history, social history. They'll reconcile all of the patient's medications and make sure that everything is correct in terms of dosing and frequency. And then we'll go through and try to identify people in the patient's family or friend network that they feel comfortable with us speaking to. There was a hand up there. The history usually comes partially from the patient, and then there's also, as I mentioned before, however many records that are available from the past.
And he doesn't remember
That
they're not getting accurate about medication. So it's dangerous.
it is, and I frequently, I shouldn't say frequently. I'm not unfrequently contacting pharmacies and maybe even county Medi-Cal pharmacy benefits managers to try to figure out what people's medications are. Because that is important information. It would be ideal if everybody would sign a release of information form so that we can actually have our EMR pull data from whatever health system they're from. But again, it's an investment and it's a work in progress. Another question in the back. Mm-hmm. 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 Yep.
Everyone should have access to how these reactive medications, the history, some of the vital history, or what he's afraid of, what he's paranoid about, what he has been. In one place, that can be the activity in the future require that to use the medical.
I'm almost positive it's in the records, and the nurses, again, are usually the first ones who touch all this information. And as I mentioned before, they start the medication reconciliation process. And that's usually reviewed with the psychiatrist when the psychiatrist does get to the case. As I mentioned before, there's anywhere from 1 to 3 psychiatrists, and the census can vary a lot, depending on different situations and circumstances. Yes?
Being a member of posters about patient life. I'm wondering, are there legal safeguards for patients once traveling their authorization?
There are safeguards. There's actually posters all across EPS and BAP as well that highlight what those rights are. Typically, if somebody does have a complaint of some sort, there's a patient advocate available, and that person will help to facilitate some of the conversation around that. Okay, should I move on? Let's see. So LPS holds. There's different kinds. There's the 5150, which most people know about, and that lasts for 3 days. There are 3 days in the emergency room or in an inpatient hospital before you then need to initiate the 5250, and then they have to appear before a mental health court judge. So the 5150 and the 5250 is where you typically see that's the most common thing you sort of see in EPS. Occasionally there are people who are conserved. There's temporary conservatorship and permanent conservatorship. NAMI Santa Clara County's website on LPS conservatorship and the 5150 is fantastic. When I was looking at it, I was wishing that when I got here to California, I'd had the chance to read it. Absolutely comprehensive and puts it in plain English. But I put it on here because the period of conservatorship is something that was new to me at the time. Maybe it's not new to you all if you've lived in California long enough, but I figured it's important to put it up there. Minors under the age of 18. We typically try to transfer them to Uplift's Crisis Stabilization Unit. You're very fortunate here in Santa Clara County to have the Crisis Stabilization Unit. It is a child-specific EPS, and it is separated from all of the adults who are 18 and over who are at EPS. And it's actually in Campbell, and we send them by ambulance with consent of the parents, and it is a fantastic resource because not only is there the Crisis Stabilization Unit, but then Uplift also has a mobile crisis team who will come out to your house and do an emergency evaluation and try to figure out where the child should go from there. So minors at EPS are relatively rare. Sometimes it does happen, and the exceptions are, as I mentioned up there, Kaiser Insurance, if they're medically complex for some reason, or if they're particularly aggressive and there's a history of violence with them at the Crisis Stabilization Unit. I don't know how many of you have had the chance to review motivational interviewing and the stages of change, but this is an infographic that talks a little bit about the different stages. I bring this up because a lot of times insight into change is something really difficult to work on. And a lot of my work I found in EPS has been sort of talking through and trying to better understand and motivate them to change. Typically, a lot more times than I'd like to admit, people who come into EPS are in a pre-contemplative stage of change, meaning that essentially they're not in a place where they want to change, and it's my job to talk through with them things that they like, things that they love, goals they might have, and ways to inspire them to take that courageous leap and try to change, because it is really, really scary to try to change. And being able to do that does require a lot of support and motivation. And so I bring this up because most of the most difficult cases at EPS that I run into are usually when they're not ready for change. And the difficulty then is figuring out, what do I do from there? Because there are some very difficult decisions to make at that point.
Like
No, I agree. I think there are a lot of people in the county who are officially trained in motivational interviewing. I mean, being the guy at EPS who's there on the weekend and not necessarily having the chance to interact with the rest of the department, I don't know them personally, but I would imagine that there are a lot of people in Santa Clara County who are trained in motivational interviewing who could help support somebody in a clinic. Now, in my emergency room, I don't know about a psychologist that's available to me, but I am there, and if I see them, we will definitely have a very thorough conversation about these stages and reasons to change. And then there's a safety evaluation. This is a very gross oversimplification of it, but the idea is to try to get an understanding of what they're thinking about in terms of whatever safety concerns brought them to my doorstep. And then there's the question of how intent are they on acting on whatever plan they might have. And then in some cases, they've even done things that might have even brought them closer to actually being able to execute the plan. So safety evaluations are really difficult. You catch them for that brief snippet of time, as you all have pointed out, and you try to get information from family and trying to figure out how best to support this client. And then you have somebody who's been at EPS for anywhere from 24 to 72 hours, and you have to take that into account also. So there's a lot that goes into the safety evaluation itself. But I talk about this, I'll get to that. I talk about this primarily because safety is a very important part of our time together at EPS. And then there's also the question of how do we help support them to keep them out of places like EPS, if at all possible. That goes into my formulation of discussion as well. And I put up this little snippet of this article because I met somebody, Joe Shinstock, up in the California legislature, and he was talking about LPS law and the definition of gravely disabled. And I admired, his interest in trying to clarify what gravely disabled means, because it's been a very difficult time trying to clarify that. And even within patient advocacy, even within advocacy at NAMI and the APA and et cetera, there's been a lot of discussion and not necessarily a general consensus agreement that I think everybody can agree upon. And so I'm not going to comment on it because, again, I'm not a legislator, but just so to say that the definition of gravely disabled is complicated because the idea is that some people are so mentally ill they can't even provide for their basic human needs, their basic physiologic needs. If you remember Maslow's hierarchy of needs, being able to get food for yourself, being able to get a roof over your head, being able to get warmth for yourself and water. This is all very basic stuff. And if you're truly gravely disabled and you're so disconnected from reality or disabled by your mental illness, then that becomes a really big problem. And at that point, we then do take action. But there's a wide spectrum by which gravely disabled is interpreted. And it's not necessarily, there's not necessarily the clear guidelines that I think Mr. Shinstock and his family are trying to come up with. So I'm looking forward to seeing what happens with that, because that will be an ongoing area of discussion over the course of the next couple of years. Okay, sorry, there's a bunch of questions now. Okay, go ahead. You're first, young lady.
Then I was told
Well, I'll say this. If there's any safety concerns, I think EPS is the best place for them to go. I certainly agree that while they're at EPS, it's important to sort of talk about what's going to happen next, because the surest chances of somebody coming back to EPS is if we don't get the chance to talk about what happens afterwards and how to prevent something like that from happening again. But I will say that Lewy body dementia is a very complex diagnosis with a lot of a lot of cross-pollination between psychiatry and neurology. And so given that, we can talk more in depth afterwards if possible, because it is a little bit more nuanced. Oh, there's a lot more questions. Okay, yes. Yes. Yep.
I think a lot of people know this was not just it was aimed at reducing
I have heard such things. I have not had the chance to. I have not had the chance to review the records officially.
This bill, what they've done, I think we can see all around this town. And in San Francisco, it's an abysmal failure. Down the line failure. They closed the hospitals, they closed places for care, and put them in group homes, vision, no follow-up, and it's a disaster, absolute disaster. And it's horrifying for families, absolutely horrifying. So they're using this language about, no, we want to take away all this inappropriate and often indefinite. Also, they're using that, I think, as a hook for cutting costs. I know there's a happy medium. We don't want to go back to the days where you said no to your mother. You know, that kind of thing.
Right, and I certainly think that's important to continue talking about with the California state legislators up in Sacramento.
I've been waiting for them to come in. Yeah, this was just for us to speak.
Yep, he's up in Sacramento.
This is very central to the problem that would happen. It's where they go after yes.
Yeah,
Pre-AIDS is not
Right.
stabilizing anything.
there's a lot more questions. I'm trying to think through.
Okay.
Okay, the young lady in the back has been very patient.
How do you, like, when our folks know, for example, that
Well, so the question was, how do you interpret gravely disabled from when one patient's transferred from one hospital to another? So gravely disabled, when I see gravely disabled, I again sort of think back to my Maslowian hierarchy of needs and try to keep things as basic as possible. And I think it's important for each clinician to really sit down and have that very detailed discussion with the patient and their family members to try to figure out exactly what's going on, what went wrong, and then what's going on now, and then what do we do next to sort of stabilize the situation. So that being said, gravely disabled is also interpreted through the mental health court judges who will rule on a 5250's validity or an LPS conservatorship. So I think it would be good to better understand how gravely disabled is interpreted amongst all of us, police, therapists, psychologists, psychiatrists, and again, the justice system. There's a deeper discussion that I think you had pointed to that we need to clarify in terms of the interpretation of gravely disabled. But that's, again, something that would probably go way beyond the short period of time that I've been allotted here. And I know there was one more question in the back, but let me try to get through this as quickly as possible. I swear, I'm going to move as quickly as I can. Medication over objection. So There are times, as I mentioned, when people are so agitated that they are physically aggressive towards either the staff at EPS or other patients at EPS, and we then do have to take emergent action at that point when people's safety are being threatened. So that's an indication when we're going to basically offer medications by mouth at first, just as we're trying to verbally de-escalate them. But if they're still physically aggressive with us, then we will have to use injectable medications at that point. The other reason why I bring up medication over objection is because more recently, and you all, since you all are so up to date on a lot of community mental health, there's what's called the Reese petition, that you can medicate someone over objection, and that a legislative official would then have to decide whether or not someone can be medicated over objection for, again, a limited period of time. So the Reese petition is something that usually happens once people get to BAP or they go to an IMD type facility, IMD, Institute of Mental, I hate saying it, I didn't want to say it, okay, well, Institute of Mental Disease facility, basically a long-term facility for severely mentally ill. But that's usually when you see something like a Reese petition. Well, not even a Reese petition once they're LPS conserved, but when they're on a 5250 or they're hospitalized somewhere, is usually when you see the Reese petition.
Is there any concern about dysfunctional families involved in something? Or could be different sometimes be different their entire family?
Well, that's a great question. So the question was about dysfunctional families affecting disease burden in the patient or client. And I'm a child and adolescent psychiatrist, so as you can imagine, I see a very important role for family in all cases. That being said, it's not uncommon for family members to have a certain effect on people, and that does factor into my decision-making process along the way. Usually, if we're lucky, then we usually have a lot more information from the past about previous presentations, and so we'll be able to get a pretty good gestalt of the case from family information, as well as like the medical records that are in the past. Okay, this is for you all, and the family and friends who are, again, very concerned, and I'm not even the one answering the phones. I'm primarily working with the nurses and the secretary staff, and they're the ones who get the initial calls. And so there's a lot of difficulty with maintaining patient autonomy and maintaining their privacy. That makes it really difficult sometimes to get all the information I really need to make a good clinical decision. One of the most frustrating things is having to do the motivational interviewing thing in order to convince them to sign the form to allow us to be able to talk with their family members. That's when you know it's already going to be an uphill discussion. But I firmly believe that family and friends are really helpful after coming to EPS and leaving from any sort of inpatient hospitalization. And so I always like to try to get collateral information from family and friends, if at all possible. And as someone very eloquently mentioned before, we're certainly not always able to provide information about the clinical care they're receiving while they're at EPS or any other information, but you can be sure that I would definitely love to hear any information you have about their case, medications, risk factors, etc. I would love to know that. And the minute I can get them past the pre-contemplative stage of motivation to sign that form, we are going to try to figure things out from there. Okay, wow, a lot of questions. You've had your hand up the longest, but there's also some people who haven't asked questions before. Let's see. The young lady in the green in the back. You know, so because I'm not very well versed in interpreting the law or knowledgeable completely about the law, I will have to find the answer to that question from one of my colleagues and try to get back to you. Okay. So the,
What's the question?
Because the patient has the right to decide whether they want the family can have contact. And that overrides our.
I say something about the HIPAA law, because I spent an hour before coming here looking at the federal site.
yes.
Okay, and it does not say what you say in that first certain point.
Okay.
It does not say it. I've been told that by perhaps 1,000 mental health. But it does not say that. So is that, now that could be a county regulation. And that's fine. But it is not, that is not regulation. I encourage everybody here to go to the federal site, the Patient's Guide to HIPAA Privacy Rule by the U.S. Department of Health and Human Services, Office of Civil Rights. And it explains the HIPAA law there, and it doesn't say that. Now, the county may say that, and that's their right to make that as a rule. I do not like that. But I do get upset when people claim that's what HIPAA says. Because I don't think anybody who's told me that has ever read the HIPAA rule.
I put it down on my phone and I could
Is it?
and I put on there that said, I said I want to contact. Only I did it within by an answer, forget, again, but it says, in the regulation, the best interest.
Right. So in an emergency situation, you know, as a physician, I am authorized to contact family against the patient's objections.
And also, not to check. Especially if it's that they're not there on weekends, so, and if you do it on Friday night, free, no, I taught it, but have to. But I agree that it's not.
Perhaps that was a little,
I'm confused by that slide.
yeah.
That however DPS can listen. I thought it was a law right. It
Yeah.
doesn't mean you can give me information about myself. I get that.
Yep.
That actually is more important. You get information.
Yep.
And I thought 80/14 was a law. They had to take that information from us. It doesn't mean you act on it, do everything I want, but you at least have to see that work and read it and make it part of the plan.
Yep.
This can, or that you have to get permission like from my son to get information from him. Oh, no.
Yeah. And sorry for my poor wording.
Okay, that's not, I didn't think that was part of it. Sorry,
No, it's okay. Wording's important.
I thought it was a law that you have to take.
Okay.
Alright, just a quick comment, the regulations actually say that if somebody is possessing outside the practice, unless the patient says no. EPS interpretation is unless the person asks
Well, again, I'm sorry for the language that I chose, number one. And then number two, um, there, the privacy piece is like, as I mentioned before, is something that I struggle with a lot in EPS. And I always like to get information from family, and I'm sorry that you've not had as much success sometimes. I will say that I have seen the form that you're talking about, now that there's a name for it, but it's not something that was necessarily always named for me. It was a very helpful document that I found in their chart that I had the chance to flip through and get a better chance to figure out what's going to happen next with the patient at that point. That being said, the privacy piece is an ongoing topic of debate in EPS, and I can assure you, all of the staff in EPS would appreciate the information that comes from family and the community. And God, do I wish the different community-based organizations were available to help coordinate care on the weekends. Because it's lonely there on the weekends. Okay, all right.
So I just wanted to point out that Dr. Duckworth is the medical director of NAMI National at Harvard. He also still practices, he works in PR. And he says that the first thing he asks patients that come in is there must be someone who loves or cares about you, that you should let them know that you're here. And, we'll tell them no visits, whatever, but that'd be a good opportunity to ask for information or get whatever.
Yep.
And he says, 90% of the patients agree to that. And, and then he said the next couple of days he works on asking that question so they're clear, and he can usually get almost all of it. So I think it's the approach that we have to think about, the way we communicate.
Yep.
And, come up with different ways that you can get the consent, without, I always tell my family members, I just want to get the information to you. I don't want to do therapy and all that stuff. That's your business. It is. They have to manage their illnesses. But I'm a caring family member, and I really get involved and get information. And I think they're going in the wrong direction because I don't want them to get arrested. I don't want them to go to the hospital, homeless, things that you come to.
Yeah, agreed. Oh boy, okay. No, it's all right. We're pretty much over time anyways, so as it's clear I'm not going to finish.
Fact machine, okay? Use the fact machine to fax to EPS for this patient, this medication worked for the last 10 years. North Carolina law is very different. California is really entrenched in Midwest, and especially EPS and all the.
Well, and I'm, honestly, even though I'm getting a lot of flames for this, I'm actually really glad that we're getting the chance to talk about it, because I do think it's something that we should take a closer look at. I do think that, again, information is really helpful in determining what's going to happen next for patients. And I wish it didn't have to be this difficult. And I would like to try to figure out how to balance patient autonomy versus general societal good at the same time. And again, it's a very complex discussion on philosophical levels that are way beyond my education.
We want to help you.
I'm delighted that you guys are here. God, it'd be great if there was like a NAMI community advocacy group for EPS, because again, the lone guy on the weekend, what can I say? I would love if you all were available to help me. Sorry.
I think.
Oh, is there?
Who's asked